Good afternoon, all. At the outset, I would like to thank Dr. Mayuri to give me this opportunity. So I will basically summarize the whole whatever we had seen in the last 5 speakers. What is the current day status? So the major beneficiary is definitely angle closure disease, which has high visual morbidity. And we all know that the early detection of anatomically narrow angles is important because a combination of various anti-segment techniques gives us a clear picture of the anatomy that helps to make an appropriate treatment decisions. So we know that indentation gonioscopy is definitely the gold standard for assessment of angle, but it has got drawbacks like it has got subjective variation and that there are various types of lenses used, and there is usually a steep learning curve, and there is variation of the assessment in different ambient illumination. Placement of the lenses, sometimes mechanical pressure is there, so it has to be avoided in damaged epithelium or opaque corneas. So the objective assessment of antechamber angle can actually be done either by a photographic method or by an optical method. For photographic method, it is usually, we have ICAM, which is a portable handheld device used in dark illumination with supine, usually very good for children. And it gives us a direct imaging of antechamber angle through almost 130-degree wide field lenses, and the data captured, they goes through a computer assembly and we get the picture. So it is actually a good objective method of visualization of antechamber angle. There is moderate to excellent intra and inter-observer reliability and good agreement with gonioscopy shown in several studies. But the drawbacks are there is poor depth assessment in narrow angle research when compared to antechamber OCT, anter-segment OCT, and is influenced by position-related changes. Pentacam images the anterior segment from cornea to posterior surface of the lens with in three dimension, but the major drawback is there is direct visualization of the angle recess is not possible. Anterior segment OCT and UBM are two most commonly used devices and discussed extensively in our with our predecessor speakers. And this anterior segment OCT is a non-contact rapid imaging device that uses low coherence interferometry to obtain cross-sectional images. It has got good reproducibility, and it is non-operator dependent, and patients are on sitting position, that is the best, and is known to have higher sensitivity when detecting angle closure compared to gonioscopy, but it is actually less specific. And there are various types. The bottom line is, if we increase the wavelength, like from 800 nanometer to 1310 nanometer, we are going to have better axial resolution and better depth range. And the moment we are using the swept source ones, the line scan rate is increasing by almost 10 to 100 times. So it gives us a fantastic qualitative assessment, but it is very important to identify the scleral spar as already discussed, and it is visible as an inward projection of the sclera at the junction between the inner scleral and corneal curvatures, and the apposition between the iris and the inner corneoscleral wall, that is the ITC, which is very important, and we need to see that. Quantitative measurement of the antechamber angle is possible with a built-in software, and definitely it requires the identification of the scleral spar, and there are several parameters which have shown good reproducibility. These are already discussed. What is new is that there are several new AS-OCT parameters that has been associated with angle closure, which includes smaller AC weight, smaller AC area, lower antechamber volume, larger lens vault, and greater iris curvature. And also, AS-OCT is invaluable for diagnosis of angle closure glaucoma, and it can detect clinically important changes in antechamber angle structure in patients with angle closure glaucoma under light versus dark conditions. And also it can demonstrate widening of the angles after laser iridotomy, and not only that, it gives a clear indication when we follow the patient following the laser iridotomy that certain amount of patients will have a non-pupillary block mechanism also, which may contribute to primary angle closure glaucoma in future. In this paper, Vaskinen et al. Looked at a cohort of almost 300 patients who had a gonioscopically open angle, but where they had detected iridotrabecular contact by Visante OCT, and they saw that the subjects with more quadrants of AS-OCT angle closure at a baseline had a greater chance of developing gonioscopic angle closure after 4 years, which was statistically significant. So thereby, AS-OCT can predict angle closure glaucoma, which is going to happen in future. The newer modality in this is a swept source OCT device. It is either from Tommy, which is called Cassia, or there is another called Anterion. It can rapidly obtain high resolution scans with 3D reconstruction. Why it is good? Because it is the probably it is it detects the spar far better than previous versions of OCT, and it is also excellent at calculating iris volume, which has been shown to be a very important determinant of future angle closure disease. This is another newer parameter called ITC index. It gives us an assessment of circumferential 360-degree angle closure. A recent study by Bhaskaran et al. Demonstrated that this index is a good diagnostic performance compared to gonioscopy. ASOCT also has limitations. It cannot image beyond posterior pigment epithelium of iris. There is no use of opaque corneas or pediatric glaucomas. And quantitative assessment depends heavily upon accurate identification of scleral spar, which is important. And Madam has already shown there are new landmarks which are coming like Bell and SL. And there is, of course, no normative database in Asia. Coming to UBM, it has already been discussed well. And it is sound waves which are converted to high resolution B-scan images, but it has got lower axial resolution than anterior-segment OCT. It has good agreement with gonioscopy. It is definitely invaluable for structures posterior to the iris pigment epithelium. Why? As because sound penetrates the pigment epithelium where light does not. It is particularly useful in opaque corneas and congenital glaucomas. Plateau iris syndrome is definitely a situation where UBM is invaluable, and also it is invaluable to detect a ciliary body tumor and the area of iridojugular contact in PDS, and sometimes it can take out a GDD tube block. So the take-home message would be anterior-segment OCT is a clear winner in ascistic anterior chamber angle when the cornea is clear and the patient can sit upright. UBM should be used when the cornea is cloudy and you suspect a pathology which resides behind the iris plane. And both these technologies allow the acquisition and comparison of objective data and the parameters, which is not possible either by slit lamp biomicroscopy or by gonioscopy. So the ASOCT and UBM prove to be useful adjuncts, but it can never replace the clinical examination by gonioscopy. At the end, let's look at what is deep learning is. The deep learning is an artificial intelligence function that imitates the working of a human brain in processing data and making decision algorithms. Application of deep learning is to assess the anterior chamber angle in ASOCT images has already been shown with encouraging results, and it is comparable with the diagnostic ability of a very well-trained ophthalmologist, and probably this is the future. Thank you for your kind attention.
Thank you, DIPANJAN. Now we can take up any questions you guys have. Yes, please.
I just wanted to, I think Dr. Mehta demonstrated very beautifully that, you see the oppositional angle closure very nicely on the anterior segment OCT, and it can very well be used as a screening tool. So ma'am, my question would be that, Asian eyes have a lot of narrow angles, and so when we do gonioscopy, we can always do indentation and see there is oppositional closure, or are the angles opening up. So is it something that if we use, for example, anterior segment OCT, we will be advising more of peripheral iridotomies and maybe, increasing the burden of laser rather than going on a little conservative approach if we do only gonioscopy?
There was a study done by Ramakrishnan et al. And they have shown that by using the imaging, you can identify a lot of angle closure, possible suspects. And that, you are right, absolutely. That may increase our burden to do laser PI. But we can use other parameters that they have discussed, both of them. Lens fault is also very important. Nowadays, iris volume is also calculated. Look at the peripheral roll of the iris. If it is a thick roll, then the occlusion is likely to be happening. So, Medha, use my gloves.
Yeah. How do you measure the volume? Can you measure with the normal OCT?
Yes.
In fact, can I suggest, the counseling becomes so easy when you've done a
Exactly.
gonioscopy is a subjective phenomena. Your eye say angle is open, angle is closed. But here in anterior segment, when you see the angle is narrow, you can explain the patient. Even if the angle is narrow on a gonioscopy, you explain beautifully. But when you show it on the picture on the OCT machine, it becomes counseling easy. What I've done now, post YAG also, I do the OCT and show that this 100% perforation has happened. Sometimes it has happened, it's not very adequate opening. You see in the anterior segment OCT. And I advise few more shots to be given. So it really works very wonderfully. And I take 4 directions, in the anterior segment OCT.
You can.
Yeah. So
It is so nicely seen with the cells in the extremes and the fluid coming from here, translucent area.
fact,
So immediately after PI, it
Dr.
is nice.
Mayuri, I say one paper read about it, It says that do the screening of anterior segment OCT of the angle and then do the gonioscopy. You may find more
Yeah,
narrow
actually
angles,
that
you
was
see.
what I was just about to say, that if you are using ASOCT as a screening tool, then you can pick up those suspicious
Yes.
cases
And
and,
then-
then subject them to
Correct,
gonioscopy.
correct,
And in
yeah.
fact, gonioscopy may give you those small additional information like patchy pigmentation or fine goniosynekia, which you could not see perhaps in the ASOCT or anything. So then it's easier for you to decide whether to go for a PI or not.
In fact, yesterday only I had one case of a traumatic injury, and it looked like the stone at about 3 o'clock near the limbus. And whether it looks like a stone, but it may be a hemorrhagic phenomena. So I just did the anterior segment OCT and I found that there is no stone because the entry wound was there. So I was wondering whether I'm dealing with a intraocular stone. So anterior segment OCT works very well in majority of the cases,
Particularly when there is a trauma, penetrating trauma, or the hyphema is there and you would like to assess the angle. There also this non-contact anterior segment imaging will give you a lot of information. Yes. Any more
And
questions?
One more,
Yes.
one more question I mean, plateau iris syndrome, when we have a double hump pattern and we have done an iridotomy. For example, I am practicing glaucoma, but I do not have an UBM. So, what should be the general take-home message that if you have done a PI and if you see a double hump pattern and the pressures and the angles are not opening, do we label or should we always send the patient for a UBM to confirm for plateau iris before we do, or just a gonioscopy and a PI and a double hump sign should be sufficient?
I don't think it is compulsory to do imaging. If you can identify on gonioscopy, it is a sign that there is an anterior rotation
wave
or
sign,
some tumor is there. And plateau iris, the question is, should we do the PI or not? That is another question that I have put up here. It is to relieve the pupillary block element that patient has. So we have to do PI. It is not for the opening up of the angle. Okay.
For your question, sine wave sign on gonioscopy.
Yes.
You
That's
can
what
look
I was
for
saying.
that when you
Yes,
see
yes.
that in spite of a PI, the patient still has an angle closure. Look for the sine wave
And then
sign.
you do a
And then you send,
iridoplasty.
then you send for a UBM if possible, because patients nowadays read up all the Google material. So if you don't get an UBM done, it's actually not a confirmatory thing for a plateau iris. So it's better to get a UBM done before you put the patient back on pilocarpine and say that you'd have to use pilocarpine for a long-term period, basically. Yeah.
Another option is actually, though it's not available right now, but you could even try pilocarpine. So if that changes the iris configuration and improves your IOP control, then that is another indirect evidence that probably it is plateau iris.
It's available now.
Dipanjan, you won't like to?
Yeah, pilocarpine is available freely now for information, yeah.
Yes.
Yes, the therapeutic
Drug
diagnosis,
of choice
exactly.
for play to iris.
Yeah. And pilocarpine is freely available now.
Not available.
Really? It's
Not available
in
to
Delhi
our
It's not
NCR.
part
available,
of the
so we
country.
did speak to, from the GSI we spoke. No, we
No,
spoke
no, no,
from the
it's not.
GSI to.
Delhi
about-
NCR
because there
to
was a
Dr.
raw
Chandriman, it's
material
not
crisis.
available.
Yeah. No, it's available for last 1 month or so everywhere.
No, no, Chandrima.
last,
In
no,
Gujarat
in
and Maharashtra, it is.
Yeah, pilokite is available and.
That
yeah.
is not available in Gujarat.
Not in Gujarat?
Actually, Dr. Chandrima,
But it's from Pune basically. It's from
but
Pune,
it is not
pilokite.
available.
Yeah.
Not available in Pune.
no, it's not available. I just wanted question not related to this because pilocarpine is not available. What do we do if you have to, can we make drops with using injection?
And that is too less in the concentration to affect the pupil and all
It's not
that.
available. Delhi NCR, though I'm pretty sure, we were struggling and
It's not available.
that is what I was asking.
It's not so effective.
Not so effective.
Not so effective.
It is already diluted. No, so how do we, you simply put those drops, you don't dilute it, no? Diluted, no?
It's already diluted.
It's very diluted, that's what.
0.5.
Yes.
Carpinol that we
0.5%.
use intracameral.
I have used intracameral like pilocarpine for drops, and I have seen that in some people it actually works. Probably those people like they have either thinner iris or something, and in some people it doesn't work at all.
Yes, absolutely.
Maybe we can increase the dose and see. I don't know how that would work. Maybe instead of 4 hourly or 6 hourly, you give it 3 hourly and see. I don't know. That's a trial actually.
But
No,
no,
we
the
have- we
letter
have. We've
came
already
from
spoken.
FDC to one doctor saying that by the end of May they will start production. It
So I
is
think
the
you should
government
try
cap
online.
that is causing the issue because they cannot raise the price and the material is very expensive.
Raw material.
Raw material. They get it from Germany or somewhere.
The raw material was a problem,
Very,
but
very
that has been
problematic.
sorted out. So
But-
I don't know why you're not getting it because we are freely getting it. And I think that company, I can send you the, the details. It's in Pune.
We will,
so you
we
need
will
to
go
get
and
across to
talk to
yeah.
them,
Yeah.
definitely. Any more questions in relation to the imaging? Back to the originality. Any concluding?
I can just ask one question.
Yes.
As if we practice anterior segment this OCT frequently always in our OPDs, then we are actually going to detect more PACS cases because it is definitely more sensitive. It is definitely more sensitive and less specific. So based on this ACE OCT ITC index or whatever the amount of iridotrabecular contact that is happening, are we going to actually advocate laser peripheral iridotomy for all these patients or not?
She just answered. She just
Yeah.
answered that.
Actually, this is used as a screening tool, so you can always do gonioscopy and confirm. You do photopic and scotopic, how the iris is behaving, and after that you can just give knowledge to the patient. So patient understands what is his anatomical position of the eye, and whenever there are symptoms, you make them aware of the symptoms. So whenever the symptoms are there, yeah,
Good enough thing, like we are basically making the patient more aware.
Aware.
You were come to this community of angle closures
yes.
and please be
And there is a very simple solution if you develop symptoms. So whenever you have symptoms, please come. We can do whatever is needed. So that in that message should be given to the patient.
Yes, it's a good tool as a screening and as well as counseling to the patient. Once you show them anatomy and dynamic changes because of the light, they do understand and they yes.
No, I use in every patient in case. I mean, may not charge them. That's a different issue.
Sir,
But there's no
charging,
harm.
we, in private we do charge them.
Few of the-
We
It's a
can't
very
do it
beautiful
free.
tool to see the angle.
It's expensive but very useful at times.
As a retina surgeon, I want to ask, if you are not dilating the pupil, then how are you going to see the retinas? Because the corollary is then you will have to buy Optos.
You have that small pupil camera, sir. Fundus camera, you have it. Full fundus view is in.
Very expensive.
Yes. So,
But if that's what, no, the answer to this is, if the patient needs repeated retinal examination, you better do PI.
better do PI.
Yeah, that is
That
one
are
thing. and
relative indications of PI.
Yesterday, actually, I was in a session which was very interesting under the Apple Tree Innovations. So there, we have people who are actually coming up with really inexpensive tools where you can actually see the fundus and the disc without dilatation of the pupil. I think once they are available commercially, we